the different parts of each one of these so that it all makes sense when we talk about it. So your autonomic nervous system is a peripheral efferent nervous system. So it's what exits the brain. It innervates your heart, your blood vessels, your visceral organs, glands, smooth muscle. And generally it's beyond our conscious control. So we have two neuron systems. And we kind of touched on this the last lecture, and we're going to really get into it. We have preganglionic nerves, and we have postganglionic nerves. All that means is the ganglia are just like a row of cell bodies where all of the impulses come into and they synapse with other neurons that leave and go to innervate the effector organs. So you have the preganglionic ones for your sympathetic and parasympathetic nervous system, and you have postganglionic ones for each of those. And these are all these are your autonomic nerves. So your preganglionic neuron, its cell body is in the spinal cord or brain. So it originates in the brain or spinal cord. And then it's modulated by higher centers in the brain and spinal reflexes. So that's what's going to trigger it and propagate an action potential down this preganglionic neuron. The axon leaves the spinal cord from your cranial, thoracic, and lumbar regions, lumbar sacral regions, and it forms synaptic connections in the autonomic ganglia with the cell body of postganglionic autonomic nerves. That is really wordy, and it will make a lot of sense. Do you guys have all these? I think I might have added some pictures, so just stop me and I'll write down the ones so that I can make this for you. So basically, you have your brain and spinal cord that have the cell body, so that's where they originate. They are going to leave, and these are preganglionic nerves that come to these cell bodies, and they're going to synapse with other neurons that go to your effector organs. And you have sympathetic ones of these, and you have parasympathetic ones. That'll be in a further slide. But most of these, they're going to synapse here and release a neurotransmitter, which is going to excite the other postganglionic neuron that's going to go to that organ. Does that make sense? Right. So your postganglionic nerves are going to send their axons directly to the effector organs. Visceral organs, thylacine, excitatory, and inhibitory responses. And this is that balance when we were talking about with your sympathetic nervous system and your parasympathetic nervous system, kind of all firing back and forth like a teeter-totter based on the needs to maintain your blood pressure, maintain homeostasis. This is another picture. So your spinal cord, you're going to have these preganglionic neurons, and they're going to release a neurotransmitter, which is going to excite your postganglionic neurons that are going to send an action potential down, release a neurotransmitter, which is going to act on the receptor of that organ. They are different based on sympathetic and parasympathetic. And these are all on further slides, but your sympathetic ones tend to be short, and they act on these cell bodies that are in your paravertebral cell bodies and have chunks, and then they have longer postganglionic neurons. Whereas your parasympathetic has a longer preganglionic neuron. It's going to synapse in cell bodies that are closer to the effector organ and have a shorter postganglionic neuron. This is just a picture. You can, again, to make sense of the pictures. So you can look at all these, and they're constantly going back and forth to maintain, your parasympathetic nervous system that acts on certain things like your eyes. It will constrict your pupils. Your sympathetic will dilate your pupils. So they're kind of all going to balance. The biggest thing about this picture that's helpful is that these preganglionic neurons are starting in your spinal cord. And if you notice for the sympathetic nervous system, they're going to synapse, your preganglionic are going to synapse in this sympathetic ganglia, or it's just a chain of cell bodies that are kind of close. So these are very short, and then they're going to send out elicit responses to all of these effector organs. The result of this with your sympathetic nervous system is you're going to have a diffuse reaction. because you have all of these, like all these cell bodies are going to synapse here and send out a bunch of postganglionic neurons. They're going to excite those, and they're going to go to they're going to go to all the effector organs. The difference is your parasympathetic are going to have these longer preganglionic neurons, and they're going to synapse closer to the effector organ. And that allows for a more discrete, very specific response. You don't want to have a very diffuse parasympathetic response because it's just not good. Some of the chemical agents that they use, like some of the names of them, but that's what they do, and that's how they elicit their responses. They have just an overwhelming diffuse parasympathetic response that can be devastating to people. So most postganglionic, those are the ones that synapse after that cell body, are non-myelinated, so they conduct impulses at relatively slow rates. So you have a preganglionic one that kind of fires quick, synapses in that cell body, and it's a little slower. And it's just because it doesn't need to be that fast. It will allow for more of a specific result. And then most preganglionic nerves are myelinated, and they conduct impulses rapidly. So it allows in that cell body some like modulation and some kind of things so that everything's not just happening so fast. And we kind of touched on this already. You have your divisions of your autonomic nerves. So in both divisions, you have preganglionic and postganglionic neurons. Those are just the two types of autonomic neurons, or autonomic nerves. But your two divisions of your autonomic nervous system are your sympathetic and parasympathetic. Your sympathetic, we talked about this, your cell bodies for the preganglionic neurons initiate in your medial cell column of the spinal cord and at the thoracic and lumbar levels. Your sympathetic nervous system, you should write this down, is called your thoracolumbar system. And that's because these cell bodies originate more in your thoracic and lumbar levels. So you have the thoracolumbar outflow. They have short, we said this before, preganglionic axons that send connections to the sympathetic ganglion outside the spinal cord. And there's 22 segmentally arranged ganglia. So those are, ganglia is just a bunch of nerve terminals. So like we saw in this picture, this is your ganglia. There's 22 of them. They kind of all originate for your sympathetic nervous system. They have these, this is the trunk, this is the body, and that's where your preganglionic neurons synapse with your postganglionic neurons. Everybody hear me? This is your intermedullary nucleus. Just so you know, kind of, for the sympathetic nervous system, where these cell bodies originate from. So they start here in your thoracolumbar region of your spine. And then they leave there, synapse in the autonomic ganglia, which are those 22 bodies that sit there. And then from there, you have long postganglionic neurons that will go to each effector organ. The postganglionic neuron cell bodies are in the paravertebral sympathetic chain. That's this. They're all here. That's where the cell body, that's where it starts for the postganglionic neuron. And they, okay, and they send their information, like I said, directly to the effector organ. So most preganglionic sympathetic neurons synapse in the paravertebral. So all of them except for the celiac, superior mesenteric, and inferior mesenteric neurons. These actually, sorry, this is so back and forth. Instead of synapsing in these cell columns, they'll actually go directly to your celiac and innervate there. So they just go directly from, even though they're sympathetic nervous system neurons, they don't synapse in that cell body. They just go directly to the effector organ. And this is just another picture if you have. So this is your sympathetic trunk. This is, all of these nerves are going to exit. Your preganglionic nerves are going to synapse in these cell bodies of your sympathetic ganglion, and they're going to elicit a response of your postganglionic neuron that's going to leave an effect upward. Does that make sense? The sympathetic nervous system has two different neurotransmitters that are important. Neurotransmitters are what's going to be released. Once that action potential comes to the end of the nerve, neurotransmitter is released, and that neurotransmitter is going to act on receptors of the postganglionic nerve and elicit that action potential that's going to propagate and go to the organ. So there's two main neurotransmitters. The first is acetylcholine. And acetylcholine mediates the synaptic transmission between preganglionic and postganglionic nerve fibers in the sympathetic pathway. So where those preganglionic nerves leave that thoracolumbar region and they synapse in that ganglia, that's where acetylcholine is going to act. There's some pictures for that. So acetylcholine is going to act on the postsynaptic receptors and cause an action potential that's going to propagate. Then norepinephrine is going to be released from the postsynaptic neurons. Norepinephrine is going to travel to the effector organs to elicit the response. So norepinephrine is released from postsynaptic neurons. Acetylcholine is released from presynaptic neurons. And anything sites that release acetylcholine as a neurotransmitter are considered cholinergic receptors. So you'll hear drugs as anticholinergics. And those are just things that block the cholinergic receptor. Sites that use norepinephrine are adrenergic. The adrenal medulla is the only thing that's a little different, and that releases epinephrine as a primary catecholamine instead of norepinephrine. Do you guys not have this slide? Mm-hmm. Oh, you do? Okay. So just another picture so that you can see. So here we have acetylcholine. This is your preganglionic neuron. It's going to release acetylcholine. Acetylcholine is going to act on this. This is a nicotinic cholinergic. That'll be later in the slide. But it's a cholinergic receptor. So acetylcholine is going to bind to this, elicit an action potential that's going to be propagated down. At the end of your postganglionic neuron, it's going to release norepinephrine, which is going to act on your alpha-1, alpha-2, beta-1, beta-2. This is your parasympathetic nervous system, and we'll go into that too. It releases acetylcholine at your preganglionic neuron. It acts on the nicotinic cholinergic receptor, and it's going to propagate an action potential down, release acetylcholine, and that's going to act on your muscarinic cholinergic receptor. These are adrenergic receptors because they bind to norepinephrine. Have I lost anybody? So the parasympathetic nervous system, since we've kind of exhausted the sympathetic nervous system, the cell bodies are giving rise to the preganglionic parasympathetic nerves originate in the brain and spinal cord, and they leave the brain and spinal cord at the cranial and sacral levels, as opposed to the thoracolumbar region. This is cranial sacral. That's an important thing to understand, like in 24 months when you guys are sitting for your boards, maybe 23 months, because those are big terms. They're, you know, I don't know, thoracolumbar and cranial sacral. Cranial outflow, tectobulbar, that's just kind of how they leave. It's just another terminology of that region of nerves and where they act. The important thing to know about the parasympathetic nervous system is the cranial nerves. And these are 3, 7, 9, and 10. I would keep that memorized forever. And it's oculomotor is 3, facial is 7, glossopharyngeal is 9, and vagus is 10. And remember, the glossopharyngeal and the vagus work important when we talked about the carotid bodies and the aortic bodies for the baroreceptors. So the parasympathetic nervous system, the ANS divisions form the pelvic nerve, and these innervate the remainder of the intestines of pelvic, viscera, the bladder, and reproductive organs. The preganglionic neurons is, and this is different than for sympathetic nervous system, they have long preganglionic neurons. The sympathetic nervous system had short, and it's synapsed in that autonomic ganglia, and had long postganglionic. The parasympathetic, like we said before, has a long preganglionic neuron that synapses with the postganglionic neuron closer to the effector organs. The neurotransmitter for both is acetylcholine at both the preganglionic and postganglionic. Another picture of the same thing that we talked about, and you can tell it might be a little bit important to understand this. Preganglionic nerve for sympathetic nervous system, short, releases acetylcholine, acts on a nicotinic cholinergic receptor, has a long postganglionic, releases norepinephrine, acts on alpha beta. Your parasympathetic nervous system here has a long preganglionic neuron, releases acetylcholine, acts on a nicotinic cholinergic receptor, has a short postganglionic one, releases acetylcholine, which acts on your muscarinic cholinergic receptors. These are adrenergic, this is cholinergic. Anything with acetylcholine that binds to its cholinergic. So autonomic regulation of peripheral and voluntary organs. So most organs, like we said before, it's a balancing act. So they have dual innervation. They have sympathetic and parasympathetic, and they have opposing responses. So blockade or inhibition of these, which you can do with medications, can lead to an exaggerated response of the other. In your sympathetic nervous system, one preganglionic neuron may synapse with many postganglionic sympathetic neurons. And that's where we said, like in that autonomic ganglia where they synapse, it provides a very diffuse response. And that's because those can synapse with multiple postganglionic neurons. Whereas the parasympathetic nervous system, because it has those longer preganglionic ones that are closer to the effector organs, it only synapses with one postganglionic one. So it's very specific. So the electrical impulses from the central nervous system result in a local depolarization of the neuronal membrane. And basically what happens is these electrical impulses kind of travel down and they selectively increase sodium permeability, so sodium goes in. The immediate repolarization follows from the selective increase in potassium permeability. So this causes an action potential. So once these are stimulated in your central nervous system, sodium goes in, then potassium goes in, and so this action potential is kind of propagated. Okay, so action potential goes down, and it goes to the end of the axon. Everybody follow me? All right, this might be preview for a lot of you. Okay, at the arrival of the action potential at the preganglionic and postganglionic nerves, it'll be released a neurotransmitter. We've already talked about this. And so these are stored in your intracellular vesicles. So basically what happens is this propagation comes down and you have either acetylcholine or norepinephrine stored in these vesicles at the end of that axon. And what happens is then you have exocytosis. So these vesicles kind of fuse with the end of the axon in response to calcium, and the neurotransmitter is released. So action potential kind of comes down to the end of the nerve, and it stops, and it just releases that neurotransmitter. And it's because potassium goes in. So calcium goes in. So you need calcium for that vesicle to kind of fuse for that exocytosis for the release of the neurotransmitter. Better picture. So propagation of your action potential comes down your nerve terminal, after it's elicited in your cell body in your brain or spinal cord. Action potential kind of comes down and calcium goes in. So calcium helps the vesicle exocytosis and fuse with the membrane, the end of your axon. This will cause a release. In this case, it's norepinephrine. Norepinephrine is going to diffuse over the cleft, and it's going to act on these adrenergic receptors. Have I lost anybody? And we said before, this is a lot of redundancies. Sympathetic and parasympathetic ganglia. The preganglionic nerves released is acetylcholine. This acts on cholinergic receptors. Cholinergic nicotinic receptors. Activation of the postjunctional membrane on the postganglionic neurons leads to increased permeability and conductance of the postganglionic nerve, and the action potential is propagated. So another action potential goes down your postganglionic neuron until it gets to the end, and then you're going to have a release of, depending on if it's sympathetic or parasympathetic, acetylcholine and norepinephrine, respectively. Another picture. Do we need to go over this one? Sure. So when the action potential reaches the postganglionic, sympathetic, and parasympathetic nerve terminals, the neurotransmitters released. Like we said, postganglionic and your sympathetic is norepinephrine, and your parasympathetic is acetylcholine. At your adrenergic neurotransmitter junctions, norepinephrine is not terminated by enzymatic deactivation. So it's not enough. So you know already, I'm sure, your acetylcholine is deactivated by acetylcholinesterase, right? So if you block acetylcholinesterase, you don't have the breakdown of acetylcholine, so you have a lot more acetylcholine. Norepinephrine isn't broken down by any enzyme. So acetylcholinesterase is an enzyme. Norepinephrine doesn't have one of these. What happens is that norepinephrine is either taken up, reuptake is what it's called, taken up again and stored in the vesicles, or it binds to form. It is inactivated by O-methylation through the enzyme catechol O-methyltransferase. Degrading it, it's just deactivating it. And this is important because there are some medications that you can use that will interfere with these. That would interfere with the reuptake of norepinephrine. I'm sure you've heard of things like that. And there's also ones that would inactivate the body. So, the adrenergic receptors, and these are ones that are bound by norepinephrine, become in two subtypes. You have alpha and beta, and I'm sure you guys know this already. You have alpha 1, alpha 2, beta 1, beta 2. And these are just subtypes of these alpha and beta receptors. And the norepinephrine will activate. Your cholinergic receptors also have two types. These are nicotinic and muscarinic. These are ones that acetylcholine will bind to and elicit a reaction. Your the nicotinic cholinergic receptors are found on your postganglionic, not the nerve terminal, but the cell body, right? So those are nicotinic cholinergic because acetylcholine is released from that preganglionic nerve, and it's going to act on the nicotinic cholinergic cell body to elicit a response. Make sense? Those are nicotinic. Anything in your sympathetic and parasympathetic ganglia, as well as your skeletal muscles, are nicotinic. The effector cells in your peripheral visceral organs are typically muscarinic. So these are your parasympathetic. When acetylcholine is released from your parasympathetic nervous system, if they move your heart, all your effector organs, these will bind to cholinergic muscarinic receptors. Does that make sense? That's when you have things like atropine will act on these, Robenal, things like that. Those will act on your cholinergic muscarinic receptors. So the take-home message is your cholinergic nicotinic are basically between your pre- and post-ganglionic in your sympathetic and parasympathetic nervous system, as well as your skeletal muscle. Okay. And then muscarinic are usually for all the other visceral organs at the end, after your post-ganglionic. On most nerve terminals, on both your adrenergic and cholinergic, they have these prejunctional alpha-adrenergic receptors. This is an alpha-2 subgroup. The reason that this is important, and I have a picture on the next slide, is that these alpha-2 subgroups are on both your parasympathetic and sympathetic nervous system. And they decrease when it's activated, this alpha-2, when it's activated, it decreases norepinephrine release. Blockade of alpha-2 receptors leads to an increase of norepinephrine output. So this is kind of your body's way of doing a negative feedback, right? So these are your postganglionic neurons, and you have these alpha-2 receptors. And when they're activated, they actually cause a decrease of norepinephrine being released. So some of the medications we're going to talk about are alpha-2 agonists, because they are going to act on the end plate of these to inhibit norepinephrine release. Yes?
I have a question.
Yes.
So you're the alpha-2 there on the post-ganglionic parasympathetic.
Yes.
If you activate that, wouldn't that block acetylcholine?
Yes, it would.
So
Yes, I pointed probably to the wrong one.
Okay.
I probably, because these are the ones that our drugs are going to act
Yeah.
on mainly. But yes, you are right. It would.
okay, so there are alpha-2 on the parasympathetic though?
There are.
Okay.
The ones that we will see that make a difference are going to be the ones that will act on your sympathetic.
Okay.
Okay.
Thank you.
Does that make any sense? Like your alpha-2 agonists.
Yeah.
You can see some of the effects from it on your parasympathetic nervous system.
However, I think by its very nature, alpha-2 is an adrenergic, so norepinephrine and epinephrine will act on the receptor as opposed to acetylcholine, because they're not muscarinic or
I think
nicotinic.
what he's saying that is
Yeah.
activation of this by norepinephrine
Yeah.
will cause an increase in release of acetylcholine.
Oh, that's interesting. Yeah, okay. Very cool. I misunderstood. I apologize.
So Sympatholytics, which is that same class of medications that we talked about later, back from our last lecture. All these are things, medications that are going to prevent the interaction of endogenous norepinephrine or sympathomimetics, things that would stimulate these receptors with the corresponding adrenergic receptors. So things that would block norepinephrine from binding to the adrenergic receptors. The first class of drugs we're going to talk about are beta blockers. So beta blockers are antagonists of norepinephrine and epinephrine at beta adrenal receptors. So just at those end plates where norepinephrine is released and you have your beta receptors, it just blocks those. The basic structure is a side chain of a beta sympathetic. So basically what you take is isoproterenol, and then they have all these different side chains of it that is what causes them to be antagonists instead of agonists. So instead of eliciting a response on that receptor, it blocks it. So it binds to the receptor and it stops any sort of action from going. You have two different types of beta receptors, right? You have beta 1 and beta 2. And so depending on these outside rings is what's going to make them cardioselective. So they might just act on beta 1 instead of both beta 1 and beta 2. So propranolol is the first beta blocker that was ever produced, and this was back in 1965. Today they have more than 20 different variations of beta blockers. And they have different half-lives, different cardioselectivity, and they have different lipid solubilities. They all exert somewhat of a membrane stabilizing effect because they inhibit the sodium channel function and impulse conduction in cardiac tissues. So propranolol is a pure antagonist. So it antagonizes both beta 1 and beta 2. They're the standard drug to which all others are compared. So the mechanism of actions of all beta blockers are they are going to competitively bind to beta ANS neurotransmitters, and this prevents the stimulation of the G protein, and therefore adenylate cyclase does not produce cyclic AMP. We'll go into all of this. It decreases intracellular calcium, which decreases inotropy, chronotropy, and tropotropy. So basically what happens is normally when norepinephrine stimulates your beta 1 or beta 2, depending, and they're in different places based on where they are in the body, it causes an increase of adenylate cyclase to form cyclic AMP in the presence of ATP. Cyclic AMP causes an increase in intracellular calcium, which then forms a contraction. So all of these, if you notice, there's this theme in all of these drugs that we talk about. They all somehow have to do with calcium at the end, which is what's going to cause the contraction. So they're all in different mechanisms, kind of decreasing the amount of calcium that goes in to prevent muscle contraction or decrease activation of that. And in turn, for beta receptors, it decreases your inotropy, chronotropy, or tropotropy. So beta blockers, because they're blocking this cyclic AMP, blocking the increase of intracellular calcium, and blocking all of these things, you have a decrease in heart rate, decreased afterload, decreased contractility, and then increased diastolic perfusion. So they decrease your heart rate and cardiac output. The effects are more pronounced in those with increased sympathetic tone. So once you kind of block those, because they have because you're blocking your sympathetic nervous system, you're going to have a better response. They can attenuate the exercise or stress-induced heart rate increases while preserving stroke volume. They reduce pacemaker rate of sinus node, and they suppress the rate of depolarization in ectopic pacemaker foci. And that's just because your pacemaker has beta receptors that are constantly being used. So if you're blocking them, then you're going to block that propagation of that action potential, that electrical impulse. And it increases the refractory period in the AV node. Chronic administration, as you know, is associated with an increased number of these receptors. So if you're chronically blocking your beta receptors, your body's going to make more beta receptors because it doesn't know. So if you abruptly stop them, then you have all these beta receptors that have nothing blocking them for all this norepinephrine to act on, so you can get a rebound effect. Does that make sense? All right, so classifications, you have non-selective and you have cardioselective, and this is just beta 1 versus beta 2. In terms of hypertension, things that we usually do, you want beta 1. Beta 2 causes things like vasodilation in your lungs and some other things. So sometimes it's really good to have cardioselective because you don't want to block vasodilation in your lungs, especially in people who are prone to things like asthma or have COPD or anything like that. So these are just a list of some of your non-selective versus your cardioselective medications. I do think it's an important, for the ones that you give a lot and you have all had experience with beta blockers, I think it's important to know which ones are cardioselective. Selectivity is obviously dose dependent, so if you give a lot, then you would have some, if it's cardioselective for beta 1, you could have some blocking of beta 2 if you give a huge dose. This is just another list of all of them. I don't expect you to memorize how much protein binding is propranolol versus metoprolol. I think this is just good for your knowledge to have. Just something as a reference that you can kind of go back to. So, in comparison. Clinical uses of beta blockers would be treatment of essential hypertension, treatment of angina, post-MI patients, pre-op hyperthyroid. You always want to block alpha before you want to block beta. Remember that for always alpha before beta. So if somebody who has is in a hyperthyroid storm or has a pheochromocytoma, I think you always want to block alpha before beta. A comes before B. And the reason is if you block the beta, because then you have all of the norepinephrine going to the alpha receptors, and you can have a dramatic response. Because some of the beta actually will cause things like vasodilation, and if you're then if you're blocking beta without blocking your alpha, then you have an exaggerated alpha response. So always alpha before beta. Suppression of cardiac arrhythmias, and that's based on that membrane stabilizing effect where it prevents the sodium. And then prevention of excess sympathetic nervous system activity. Much like everything we do, we have beta blockers have some undesired effects. One can cause CHF, and that's because when the sympathetic drive is eliminated, the stroke volume and cardiac rate decline, and they can end up causing CHF. So sometimes having that increased rate in people who are prone to it just helps keep that cardiac output, because it helps keep that stroke volume and rate going to get to keep the heart pumping out. And then if you don't have that, if you block that, then it kind of gets backed up. Does that make sense? It can cause bradycardia, obviously. It can cause an AV block, cause some bronchospasm, and that's particularly true in ones who are not beta or not courteous blockers. It can cause hypoglycemia, and that's because it causes suppression of the hepatic glucose release via the beta-2 receptors in your pancreas. And it can cause hyperkalemia in patients with renal failure because it blocks the sodium, potassium, ATPase. It can cause sedation. It can also cause suffocation, altered vascular responses, and it can possibly precipitate angina with abrupt discontinuation. And that's just because you have an upregulation of all of those beta receptors. Overdose. This is another important thing to know for careers. Overdose for beta blockers, the first line of treatment is glucagon. And that's because it stimulates adenylyl cyclase independent of the beta receptor. So remember, beta, when it's stimulated, it will act on the adenylyl cyclase to increase cyclic AMP, which increases your calcium to come in. So glucagon, if you do that, it stimulates that same cell differently. So it doesn't have anything to do, which will increase your adenylyl cyclase and increase your cyclic AMP. So if you take a very simple thing, if you block your beta and you don't have any of this and you have too much, this will increase your cyclic AMP, which will increase your calcium and increase your contrast. Okay. So glucagon is always first line treatment. The other things you can do is give a beta agonist like isoproterenol, dopamine, something that will competitively act on the beta receptor. Another for your information slide, it's not something that I'm going to test you on. I think it's just good to know that it's a good reference so that you can kind of see which ones have better membrane stabilizing effects, things like that. This is just so you kind of know your first generation was propranolol. Second generation are things like metoprolol that are selective. You have some non-selective like carvedilol. And just so you kind of see where these classes fall into. Your beta-1 selective are preferred for patients who have pulmonary disease, asthma, who have insulin-dependent diabetes, and that's because you don't want to block that beta-2 that causes the insulin release. And then those with sympathetic peripheral vascular disease, and that's because beta-2 receptors, when stimulated, can actually cause vasodilation in that microvasculature. So if they have peripheral vascular disease, you would rather have one that doesn't block beta-2. They're unlikely to produce bronchospasm, decreased peripheral blood flow, or mask hypoglycemia. So just to get into the specifics of a couple of them, for propranolol, it's non-selective, as we said. It lacks intrinsic sympathomimetic activity, so it's a pure antagonist, so it doesn't do anything to activate the receptors. It completely blocks them. Blockade of beta-1 and beta-2 is about equal. It's the standard, like we said before, to which all drugs are. The cardiac effects of propranolol, most affect the heart. You'll have decreased heart rate and cardiac output, especially during exercise or with increased sympathetic nervous system activity. This heart rate slowing lasts longer than the negative inotropic effects, and so there might be a possible subtype of receptors in this axon because they don't act the same for the same length. Contaminant blockade of beta-2 receptors increases peripheral vascular resistance, and that's just because you don't have those beta-2 activation that causes the vasodilation in those venous catechments. And this can also increase coronary resistance. So this might not be great in somebody who has bad coronary artery disease. Prolongation of your systolic ejection and dilation of cardiac ventricles increases your myocardial oxygen requirements. The oxygen-sparing effect and decreased heart rate, myocardial contractility predominate. So it's not like it's going to cause them to have any sort of ischemia. The other ones, the decrease in heart rate and decrease in contractility, will kind of override these effects, but it's still kind of good to know in the background. Pharmacokinetics is absorbed rapidly, it completely from the GI tract, has extensive hepatic first-pass metabolism, about 70% with oral doses. Large patient variation, with up to 20-fold differences in plasma concentration, so it's not very reliable for patients. But we don't prescribe it, so it's just kind of good to know. If you see somebody who has it or who's recently been put on it and they have a marked response to it, you just kind of keep that in the back of your mind because you know that there's so much difference in patients. And then the hepatic metabolism is the reason oral dose must be substantially greater than the IV dose. It's extensively bound to plasma proteins. It has heparin-induced increases in free fatty acids cause decreased plasma protein binding. So that means there will be more drug available to act on the receptors if it's decreased protein binding. And then hemodilution or coronary bypass may alter protein binding as well. So if there's altered protein binding because this is a highly protein-bound drug, then that means there could be more drug to act on this site. So you might have a larger response. The metabolism, it's metabolized in the liver, has an active metabolite, and this is about equivalent activity as the parent drug. So you can have, even though it's being metabolized, you can still have the effects of it because it's an active metabolite. So the beta blockade is greater after equivalent doses of oral and IV drug related to this metabolite. Elimination is 2 to 3 hours. So metabolism is greatly reduced and decreased hepatic blood flow. That makes sense if it's metabolized in the liver and you have decreased renal or liver hepatic blood flow, then it's not going to be metabolized. Propranolol may decrease its own clearance rate by decreasing cardiac output and hepatic blood flow. Renal failure does not alter the elimination half-life, but accumulation of metabolites may occur. Because it has this active metabolite, you might see the response prolong. This also reduces the clearance of amyloid anesthetics. This is things like lidocaine and bupivacaine by decreasing the hepatic blood flow and inhibiting the metabolism in the liver. And this is important if you think of like your max doses of bupivacaine and lidocaine and things that are. Just consider that anytime you have a patient. Opioid clearance, the first Pulmonary first-pass uptake of fentanyl is substantially reduced with the chronic propranolol use.
It's weird.
Any questions about propranolol? Table, you don't need to memorize tables. But just so you kind of get an idea of their lipid solubility, which ones like characteristics and alpha blocking, but it does block some alpha. So this is another good one to know. Like if you have somebody who's under anesthesia and they're hypertensive and their heart rate's 70 and you kind of don't really want to give hydralazine because maybe they're old and you really don't want to see a marked increase in their heart rate, you can give labetalol because that will kind of, you don't get as much bradycardia from it, but you get, because it blocks the alpha, you'll get a really good decrease in blood pressure without as drastic decrease in their heart rate, as well as you'll get a good decrease in their blood pressure without as drastic increase in their heart rate as you would give hydralazine. You give labetalol prolonged. Labetalol, because it also blocks beta-2, you always want to be cognizant of people that you don't want to block beta-2, which sometimes diabetes. That's not as big a concern for us under anesthesia as people with asthma. So you want to kind of weigh those out. If they have really bad asthma, I probably wouldn't go with some labetalol. I'd probably go with either hydralazine or metoprolol. So uses of labetalol would be hyperdynamic hypertension, tachyphylaxis with nitrite, intracranial hypertension, and toxemia pregnancy. They give this to people with preeclampsia. That's all that toxemia. It's preeclampsia. They give it to people with preeclampsia a lot. Very high doses too. Labetalol, the presence of the alpha blockade results in less bradycardia and negative inotropic properties compared to other beta blockers. Some of the side effects are it can cause some paresthesia, and it causes like the paresthesia would be seen as like scalp tingling, and it can cause some urinary retention. Sorry, I'm looking at my watch. I'm just making sure we're good on time. You guys doing okay? All right. The pharmacokinetics of labetalol, the onset action is 2 to 5 minutes, so it's pretty quick, which is a good thing. Remember, hydralazine would take like 5 to 20 minutes. So labetalol would be a little better if you're kind of not wanting to reduce your heart rate too much. Labetalol is a good choice. Peak effect is 5 to 15 minutes. It lasts 2 to 4 hours, and hydralazine was like could be up to 8 hours. So this is a little shorter MD too. So it's another kind of better when you have somebody under anesthesia. It's moderately lipid soluble. It does cross the placenta and the blood-brain barrier. Protein binding is around 50%, so you're not as concerned when there's alterations in plasma proteins. Half-life is 2.5 to 8 hours, and less than 5% is excreted when changed in the urine. Any questions on labetalol? So another sympatholytic is an alpha antagonist. We talked about beta blockers, the ones that only block beta 1, ones that block both beta 1, beta 2, and then ones that block beta 1, beta 2, and alpha 1. Now we're just going to talk about alpha antagonists. So what alpha antagonists do is they convert the vascular response to norepinephrine from vasoconstriction to vasodilation. And as you remember, on the vascular smooth muscle, there are alpha receptors, right? Mainly, there's alpha 1 and alpha 2, and there's also alpha 2 here. But in blocking these, it will decrease IP3, which decreases cyclic AMP, which decrease, well, these are two different pathways, but both of these will decrease intracellular calcium, which will lead to vasodilation. So intracellular calcium leads to contraction. Phentolamine. This is a non-selective alpha blocker, so it's going to block both alpha 1 and alpha 2 receptors equally. It results in a decreased intracellular calcium and vasodilation. And so on this, just the two different mechanisms, it's blocking both of these. So it's going to block that increase in IP3, and it's going to block, and it's going to cause an increase in cyclic AMP in these, which will cause vasodilation. This is one of these things that makes it's very hard to understand. But in your beta receptors, an increase in cyclic AMP causes an increase in calcium, which causes your response. In vascular smooth muscle, it's a decrease in cyclic AMP, which causes an increase. So it's kind of backwards, but the end result is the same, okay? You will not be tested on that, but just so you know that it's just different. And it's just through different mechanisms, the end result would be a decrease in calcium in, so it causes vasodilation. Calcium, when it's in, will cause constriction, so you're by these two different pathways, all you're doing is decreasing calcium. Yes?
As you were going through that,
Yes.
how were you getting that they were blocking it? Just from looking at it.
So
visually?
basically, it's stimulating. This is a very simplistic
Oh, okay.
picture, and I will get you a better one if you want, because I love pictures. But basically what happens is when you stimulate an alpha-1 receptor, an alpha-1 receptor stimulation through this G-coupled protein will cause an increase in IP3. And IP3 in its own independent pathway will increase intracellular calcium, which will cause contraction. That's when you normally agonize the receptor or stimulate it. If you're blocking it, then you're blocking this G-coupled protein, you're blocking the increase in IP3, and you're blocking the calcium in and contraction, so it causes vasodilation. Separately, alpha-2 with a different G-coupled protein causes a decrease in cyclic AMP. And this is where it's confusing because on your beta receptors, it's an increase in cyclic AMP, which is going to increase your intracellular calcium. In smooth muscle, it's a decrease in cyclic AMP, which will increase your cellular. So if you block these, you're not going to have this decrease in cyclic AMP. You're not going to have the muscle contraction. Does that make any sense?
Yes.
I know it's confusing.
I thought you were saying that was showing that it was blocked and it wasn't under.
Oh yeah, no. This is, I think this is just
Okay, got it.
one. So if you block this, then you're blocking all this, and you'll have vasodilation because you're not. So phentolamine, again, non-selecting alpha blocker, blocks alpha-1. So this is a short-lived and reversible blockade. It can cause tachycardia and hypotension. This is used in the management of a pheochromocytoma, vasoconstriction, secondary to extravasation. So basically, the times that you would use phentolamine, and they will always be alpha blocked before they're beta blocked, is in a situation where you have somebody where they're in a hypertensive crisis, like a pheochromocytoma, something like that. And they'll be on this, and then they should be on this, and you don't ever want to give somebody a beta blocker who is not alpha blocked. And this one's nice because it blocks both alpha and beta a short time, so it doesn't last long. Phentolamine, the alpha-2 presynaptic blockade, and that's those alpha-2 receptors that, remember, when those are stimulated, they cause a decrease in norepinephrine release. Do you remember that on those presynaptic cells we talked about before? So this, because you're blocking those, you can actually have an increase in norepinephrine release because that's that negative feedback mechanism. So you can have some increased norepinephrine levels, which can increase your cardiac output. So you caution people with coronary artery disease, and you can have reflex tachycardia. Pharmacokinetics, immediate when you give it. Duration of action is 10 to 15 minutes, so it's short. So that's a good thing. Somebody that you don't want to have for long periods of time. It's metabolized by the liver. Half-life is 19 minutes, and only 10% is unchanged in the urine. So phenoxybenzamine is another one that you will see. And the difference between this is also non-selective, so it's going to block both those alpha and beta receptors. This one actually is 100 times more potent on alpha-1 than alpha-2, so that's good because you maintain that alpha-2 where it will release some more epinephrine. So this is a little more safer in patients with like coronary artery disease, so you don't have that buildup of more epinephrine. The problem with this, did you guys all take chemistry? You're taking it now, probably, right?
We had one class.
You had one class?
One
Okay.
semester.
One semester. So the difference with phenoxybenzamine versus phentolamine, they're both non-selective, is that this will bind covalently. Anytime you have a covalent bond, it will not dissociate, okay? So it's a very, very strong bond, so once it binds to that receptor covalently, it is not coming off until that receptor kind of is reproduced by the body for the long period of time. So that's just one thing to keep in that. It's binding covalently, it will last for a long time. The uses for this would be a pheochromocytoma, and that's somebody who is being treated before they're going to surgery for it. So if they're on this, you just realize that those alpha receptors are still going to be blocked even though they remove the pheochromocytoma. Once they remove that and you have all this decrease in norepinephrine, you're going to have alpha receptors that are completely blocked, and it's going to make it a little more difficult for you to treat hypotension. BPH, the major one is pheochromocytoma. These are neurogenic bladder and excessive vasoconstriction and hemorrhagic shock. That's the other one that you might see it in, but the only time I've ever seen it was with FBO. This can cause an impairment of compensatory vasoconstriction and large blood pressure reductions in response to blood loss or vasodilating drugs. Cardiac output is often increased, probably because it does block that alpha 2 as well. Renal blood flow is not greatly changed. Cerebral and coronary vascular resistance is not changed. So the pharmacokinetics, onset's about 2 hours, peak effect is 4 to 6 hours. Duration, it can continue for 4 or more days. Why? Because it's bound covalently to that receptor. So you have to wait till the receptor totally regenerates. Half-life 18 to 24 hours, eliminations primarily in urine and feces. The undesirable effects are it prevents the inhibitory action of epinephrine on secretion of insulin, can cause meiosis, and it's related to the prevention of the stimulation of the radial fibers of the iris, can cause some sedation and some nasal congestion. So that's another non-selective alpha antagonist. Now we're going to go to prazosin, or minipress is another name. It's an alpha-1 selective blocker. So you have vasodilation of the veins and arterioles. You have a decrease in the total peripheral resistance, decrease in blood pressure. It's not likely to elicit an increase in cardiac output or renin release because the alpha-2 is not effective. And it's often combined with a diuretic. So that alpha-2 is not being blocked, so you have that normal inhibition on those pre-ganglion or the presynaptic nerve endings. So it's not releasing more and more epinephrine. Okay. This acts more on your veins than arteries, so it causes more venous and arterial vasodilation, which can cause some orthostatic hypotension. So use in caution in patients with hypovolemia. Uses are for essential hypertension. CHF, it decreases afterload. It can be used for pre-op preparation for people with pheochromocytoma. Do you hear this theme with these alpha blockers and the pheos? And it can be used to relieve Raynaud's vasospasm, the red hands, yes.
So when alpha-1 is blocked, the norepinephrine is not released.
So when alpha-1, so what we're talking about, the alpha-2 receptors on that presynaptic thing, when that is being stimulated, alpha-2 prevents the release of norepinephrine. Okay, so if alpha-2 is blocked, you have more and more epinephrine released. So it's not so much that negative feedback mechanism is maintained because you're not blocking that alpha-2 receptor. Does that make any sense?
That makes sense, yeah.
Okay.
I get alpha-2, I don't get alpha-1.
Alpha-1, it's just that you're not blocking this. So when you block alpha-1, what you're doing is you're blocking that increase in IP3 on your smooth muscle bed, and you're decreasing the amount of intracellular calcium, and that causes relaxation because you're blocking that.
Okay.
Or think about what Neo does. You know, like it's a alpha-1 agonist, right? So it's just going to increase peripheral vascular resistance. So if you block that, then it's going to go down.
Yeah.
Or it can't compensate, more or less.
So the alpha 1 would vasoconstrict,
Constrict.
and then alpha 2 deals with the more
Epinephrine.
Which is why it's kind of nice, because then you don't have all this excess norepinephrine floating around because you're blocking those alpha 2, which your body's made as it's kind of a checks and balances system, so that there's not too much that. I mean, it's kind of brilliant how all of these things act together, and we try to alter them with pharmacology, but we can alter a good thing too, and that's what happens when it's non-selective.
Yeah.
So side effects of Prejunctional can be vertigo, fluid retention, orthostatic hypotension, mouth dryness, vasocongestion, nightmares, urinary frequency, lots of things. So we don't give this all that much, but you might see patients. So the onset, PO is 30 minutes, duration 4 to 6 hours. It is highly protein bound, so that might be, I mean, we don't really give it so much, so, but you might see greater effects if it's somebody that has alterations in plasma protein. Their metabolism is sympathetic. Its bioavailability is greatly, there's a huge range between 40 and 80%. Elimination is 10% is extreme, unchanged in urine. So we talked about our alpha blockers, we talked about our beta blockers. And on both of them, we had some that are selected for just the beta 1 and beta, versus beta 1 and beta 2, same with alpha. Now we're going to talk about our alpha 2 agonists. And what those are going to do is those are going to stimulate that presynaptic alpha 2 receptor. When it's stimulated, it reduces norepinephrine release. Okay. So, like we talked about, there's different subsets of this alpha 2 receptor. There's alpha 2A, alpha 2B, alpha 2C. Alpha 2A stimulation causes sedation, analgesia, sympatholysis. Okay, this will be really important in some of these drugs. Alpha 2B, when it's stimulated, it can stop you from shivering. It's an anti-shivering medication. The antihypertensive effects of these alpha 2 agonists result from stimulating the inhibitory neurons in the medullary vasomotor center. So this will, in your medulla, you have alpha 2 receptors. So when you stimulate these, what they're doing is they're inhibitory neurons. So stimulating this neuron is actually going to inhibit the vasomotor center. Does that make any sense? So it's going to like kind of stop that vasomotor center. So what is going to happen with that is it's going to decrease your blood pressure, decrease your heart rate, decrease your cardiac output, and cause vasodilation because you have decreased sympathetic activity in your peripheral tissues. Does that make sense? The nice thing about this for an anesthesia, and why we use some of these, not even just for antihypertensive medications, is you have some sedating effects. And this is because stimulating the alpha 2A receptors modifies the function of potassium channels in your central nervous system. And this hyperpolarizes the membranes, and it can cause sedation, analgesia, and anxiolysis. So essentially, these stimulated presynaptic alpha 2 receptors in the sympathetic postganglionic neurons, and it also stimulates the postsynaptic alpha 2 receptors in the medulla. In the medulla is what causes the inhibition of the sympathetic nervous system outflow. Acting on the presynaptic alpha 2 receptors in the postganglionic neurons is what's going to release more, prevent the release of norepinephrine at the site. So it works in 2 ways. Does that make sense? It works in the brain and it works down at the site. So it acts on the postsynaptic alpha 2 receptors in the medulla. So at the hear me out. Picture this in your medulla, okay? Stimulating this alpha-2 receptor in your medulla is going to inhibit your sympathetic nervous system outflow. So it's going to prevent up in your brain stem. It's going to inhibit all the sympathetic nervous system. So it's acting there, but it's also acting presynaptically at the end plates to act on this alpha-2 receptor. And when this is activated, it prevents the release of norepinephrine at the site. So does that make any sense?
So it prevents the release of the acetylcholine to stimulate the
Okay, that's what so it's opposite essentially, and then
Yes.
Right.
Yeah. So it stops it too. Okay. So this inhibits the sympathetic nervous system outflow from the central nervous system, causes peripheral vasodilation, decreased heart rate, cardiac output, and blood pressure. You have the stimulation of alpha-2 receptors in your substantia gelatinosa in your spinal cord. Just hear me out. It inhibits the release of substance P, and it can cause analgesia. So it's activating in your brain. It's activating the alpha-2 in your spinal cord and at the site. Okay. The end result would be a decrease in your sympathetic outflow. Analgesia, because it's acting in your spinal cord, in your substantia gelatinosa. This is why it's a really good anesthetic drug. And then at the site, it causes vasodilation. All right, so the two medications that you'll see a lot that we use are dexmedetomidine and clonidine. And they really act on these alpha-2 receptors that causes negative feedback to prevent the release of more epinephrine. Yes.
Maybe I didn't understand, but you said that alpha and beta receptors are adrenergic receptors, right?
Yes.
So, so from the presynaptic neuron, we have release of acetylcholine, right?
This is more epinephrine. This is
So sympathetic.
This is your post-ganglionic presynaptic. So this is, I think that's where you're getting confused. So you, basically, preganglionic nerves and postganglionic nerves, it's just two different nerves.
Yeah.
On both of them, you have a cell body that starts, and you have the end,
The axon terminal.
the axon terminal.
Okay.
Where that is, on this one, depending on both the preganglionic and postganglionic nerves, you're going to have a presynaptic receptor because it's before that synapse with whatever it's synapsing. Does that make sense? So this is your postsynaptic neuron. So it's already synapsed once. Postsynaptic for your sympathetic nervous system, and that's an adrenergic receptor. This is presynaptic because it's before the synapse. If this alpha-2 receptor was here, this would be a postsynaptic response. It would act on the postsynaptic receptor. Does that make any sense?
Sort of, but not
I
really.
wish I could
That's a
draw.
post-ganglionic
Right,
presynaptic
yeah.
site.
If you want to draw, you can.
Okay. But, I can draw. Okay. You guys give me underlying drawings. Okay. So the way I think of this is, and then you have a cell body here for both of these. And then you have muscle or whatever your end organ is,
Receptors,
okay? So this is preganglionic. This is presynaptic. This is postsynaptic. Any receptors on here?
So you have alpha on both?
Yeah.
You do, yes. You
Yeah.
have alpha-2 here and alpha-2 here. And so this is a presynaptic, postganglionic, receptor. Okay, and this is a adrenergic because norepinephrine acts on it. Does that make any sense?
norepinephrine is released there, right? From that whole.
Also,
No, so this is.
it's a negative feedback
So
loop on
in
itself.
in this thing, you have your alpha receptor, okay? This is presynaptic. You also have an alpha 2 receptor, presynaptic and postsynaptic, okay? Adrenergic, all it means is a receptor that norepinephrine can bind to. So it doesn't matter if it's here, they're adrenergic. This, because it's here, it releases acetylcholine. So this is cholinergic. Have I lost everybody? So what we're talking about here are presynaptic, because it's before, adrenergic receptors, because norepinephrine acts on this. It's an alpha 2 receptor, so norepinephrine is going to elicit it. What we're doing is we're going to give a drug that's going to act like norepinephrine just here at these alpha 2s. And it's going to elicit their response. Alpha 2 presynaptically prevents the release of norepinephrine, so it's like a negative feedback mechanism. Because norepinephrine is being released, and so norepinephrine will come back over. So it's not like a crazy illicit response. So you have this huge increase in your blood pressure. The norepinephrine that's going to act here is also going to come back and act here for a negative feedback mechanism. Yes.
Is it right to think that basically adrenergic is to the effector organ?
Yes.
So
Yes, it's just a
that's-
receptor.
Yeah.
Yes.
It's to the
It's an
effector
ANS,
organ.
yeah.
Acetylcholine is cholinergic.
Yes.
It's
That's
okay.
a receptor that acetylcholine is.
So
Also,
it's like how neurons talk to neurons.
quick question. Me and my friends here, we had a debate on Prejudic
Okay.
and its main use. So I understand here now it has like antihypertensive effects, sedative effects.
Yes.
I've only seen it used as a sedative.
Yes.
The last sedative before you're weaning up a patient about to extubate. So I don't understand how it has both. Like I really don't understand how I've never seen it used as an antihypertensive.
It's not really. You're going to use clonidine really, and you're going to use Precedex or dexmedetomidine as more of an anesthetic or a sedative. They will still have these properties because it's an alpha 2 agonist, so it will still decrease your blood pressure. That's a side effect of it for this reason. Does that make any sense?
Okay, so it acts.
Yeah, you don't usually give, I've never seen Precedex given, dexmedetomidine given as a mean to reduce blood pressure. It's
Okay.
given more because it has the analgesic, anxiolytic, sedating effects, but it's also an alpha 2 agonist, which falls into this classification. Does that make
Okay,
sense?
so
Or, yeah.
I guess what I'm thinking is if it has sedative effects, then it's like, you know how we're thinking about craniosacral for,
Sympathetic.
it's in the brain,
Yes.
but if it has alpha 2, it has also alpha 2 adrenergic.
I see what you're saying.
Oh,
You're
where
thinking
does
of you're getting confused with the thoracolumbar versus craniosacral.
Right.
So craniosacral, it's only where the nerves come from is an outflow. They all originate in the brain. And the thing about alpha 2 is that for your sympathetic nervous system, it's where the cell bodies kind of come out and originate from to go to the, I guess I'm trying to figure out a good way to say this. So just because it's craniosacral doesn't mean that the alpha 2 effects that are happening, that's in the brain. It's not because of anything with the thoracolumbar system. So craniosacral is always going to be your parasympathetic nervous system. Thoracolumbar is always going to be your your sympathetic, and that's just where the outflow tract of your nerves comes from.
Okay.
Okay, it doesn't have
Where it
anything to do with
originates.
because there's different centers in their brain that can activate, but it's where they leave. They kind of condense and where they leave. Yes.
So like there are receptors everywhere. You know, there are central alphas, there are peripheral alphas. This is just all peripheral. But like the action, the sedative action is central alpha.
Yes.
Yeah.
This
Yeah.
is just to try to get it
Yeah.
confused, because I think
Right.
there was a confusion with the preganglionic, postganglionic,
Right.
cholinergic, adrenergic. I mean, there's so many words that it does get jumbled up.
Sure.
They're all kind of separate things that intertwine.
But there are synapses everywhere. In fact, like on the end of that picture, there's like
Yeah.
8 different 8 million synapses on that one.
Yes,
Yeah.
absolutely. And dexmedetomidine or Presidex really acts centrally, which is why it's such a good drug for sedation, for weaning patients off meds. We use it a lot in anesthesia for patients that you want to keep comfortable but want them awake at certain times. Like you'll do them in pediatrics in some of the big neuro cases, with neurospine cases, and actually wake up a child in the middle of anesthesia to make sure that they can move. You have them on dexmedetomidine and they're comfortable and they're breathing and they don't care, but they're awake and they can respond.
I'm sure that was revolutionary when it came out.
It was.
Yeah.
It was very hard to get.
Yeah.
The problem is because it does that centrally on the alpha 2, it also acts peripherally on alpha 2. So you'll see things like hypotension, profound hypotension. You'll see bradycardia. You know.
Okay.
Does that make any sense?
Yeah.
Does that help clarify?
Can I go back to his point originally? Like the reason why we were saying that it was beneficial in alcohol withdrawal patients because of its sedative effects and central effects, but it also you wanted, if they were actively withdrawing, they're going to be hypertensive, tachycardic. So those the peripheral effects is what was also beneficial in that case.
Exactly.
And I didn't understand how it could do both, but now I get it more.
Thank you.
The way I remembered Prejudice was it gives the same type of effect as propofol without the respiratory function.
Yeah. So.
I think that's a ish. I think for pharmacology purposes, we can't say that because propofol is more GABA.
Yeah.
Yeah.
So, but yes, it does.
Hypotension.
The cool thing about it, the coolest case I've used dexmedetomidine and Presidex on was we had to take a 10 years old, and we had to take him to interventional radiology to find where his tumor was. Like, so we were doing like, and he was asleep for this, but we had to then wake him up with pins in his head to go directly to the radiation center to have radiation on this tumor. And this was like an 8-hour case or something where it was, and so we used Presidex on him. He was totally asleep for when he was in interventional radiology. We brought him back, we started him on Presidex, woke him up, and he was in this like lucid, he followed every command, but he needed to be awake so we could see, like, I forget exactly what he was. While he was in radiology, we couldn't have him under general anesthesia, and it was amazing. And he kind of remembered things, but he didn't care, he wasn't hurting. And a little kid, in pins, you know, holding still, and he was totally happy. It's an amazing medication. So it's great for people weaning them off because they are breathing, but they're comfortable. So they're not fighting the tube. You can actually do it without over sedating them, giving them tons of, benzos and things like that. So the types of them are clonidine. Excuse me for 1 second. I'm just gonna text Tammy. Clonidine, dexmedetomidine, and then methyldopa. And again, these are just kind of the different pathways of norepinephrine and how it blocks or agonizes alpha-2 receptors. So it has alpha-2 agonist to alpha-1 agonist 220 times to 1. So there's not really much alpha-1 agonism, so you're not going to get a profound vasoconstriction. You're going to get the vasodilation. The central actions are angiolysis. Clonidine is a pre-anesthetic medication. Give 5 mics per kilo, and it blunts the reflex tachycardia with laryngoscopy, decreases in heart rate, blood pressure, ability, and decreases plasma catecholamines, decreases NAC by 15 to 50%. So it's really nice as a pre-anesthetic medication. Can cause sedation and analgesia, and these are from the alpha-2 receptors in your spinal cord. Yes.
Does it have so some of the same, let's say, like delirium connotations in elderly? I don't know. Like, I mean, I can certainly look it up. I was just curious.
Like
Yeah.
something that you would worry about for a week or two, like when you give.
Yeah, like when you give benzos and versa. Yeah.
I don't know. That's
Okay.
a good question.
Sure. Just wondering if you could do that instead.
Side effects, sedation.
Oh yeah.
Xerostomia may require an anticholinergic to treat bradycardia during the anesthetic, sodium and water retention, rash, and rebound hypertension with abrupt discontinuation. And you can treat with hydralazine or nitrite. The pharmacokinetics, the onset is about 30 minutes to an hour, duration lasts 6 to 10 hours. So it's highly lipid soluble. It obviously, if it produces that much sedation, it crosses over the blood-brain barrier. It is readily into the extravascular sites. The protein binding is low, so you don't have to worry about it so much in patients with protein deficiency. Bioavailability is a lot, and it doesn't vary too much. Half-life is 6 to 20 hours, and in renal impairment, it greatly increases. So you do want to think about that in somebody you're giving them clonidine for a pre-anesthetic. That is going to last a while. And then elimination is 65% excreted in the urine. Methodopa, again, I don't want you to harp too much on this, just it's for your information. The peak hypotensive effect is 3 to 6 hours, the duration is 12 to 24 hours. It does cross the placenta. Protein binding is low, so you don't have to worry about that too much. Metabolism, it's metabolized intestinally in the liver. And the half-life is about 75 to 80 minutes. In stage renal disease, a little longer, but less than clonidine. And elimination, 85% of metabolites appear in urine in 24 hours. So dexmedetomidine, why it's so good for anesthesia, it's because it's so potent, and it's a full agonist. So there's not any number one agonism. It's 7 to 10 times more selective for alpha-2 than clonidine. It has a short duration of action, which is also really nice because when you want it off, it's off, and patients wake up and they're happy. And then it decreases the level of arousal. So patients are very calm and they're easily aroused. And it's amazing. You just, and they're totally happy. So you can think of it, even people with neurospine surgeries, having huge rods in their back, how painful that would be. They're woken up in the middle of surgery to make sure that they can still move and they're happy. So it's amazing medication. You can use it as a pre-treatment. It attenuates the hemodynamic responses to intubation, decreases plasma catecholamine concentration, and it decreases the requirements for inhaled anesthetics and opioids. And it increases your likelihood of hypotension. The perioperative and ICU dose is 0.2 to 0.7 mics per kilo per hour. It's decreasing your MAC, obviously, because it's sedating. It causes a dose-dependent analgesia and sedation, mild depression and ventilation, but the nice thing is they remain breathing. It inhibits the thermoregulatory control, which promotes perioperative hypothermia. So you've got to keep them warm, and it may be effective for shivering. Has weak inhibition of the cytochrome P450 system, so it might impair metabolisms of opioids, but then I think they don't need a whole lot of opioids because it has such a good analgesic effect as well. So high dose produces TiVo without ventilatory depression, so you would give 1 mic per kilo followed by 5 to 10 mics per kilo per hour. Sometimes it's about 2 to 3 hours, but they're waking up within 10 to 20 minutes, even though it's just redistributed. overdose treatment, you can give anticonazepam, and that's an alpha-2 antagonist. So that's selective alpha-2 antagonist.